Start? Great. Okay. Well, good afternoon, everyone, and welcome to the weekly graduate seminar series at the Dahdaleh Institute for Global Health Research. My name is James Urbinski, and I'm the director of the Dahdaleh Institute for Global Health Research, and I'm delighted to host today Firdosi Mehta, who's going to lead today's seminar, which is titled Building a Career with the World Health Organization, My Journey. And before we begin, as is our usual practice, I'd like to begin by acknowledging the Indigenous land that we are on. As this is a hybrid event, some guests are on different territories, so please take the time to give thanks and respect to the land on which you are currently living and working. And today I'm here at the York University campus here in Toronto. And York University is situated on the traditional territorial area known as Takaronto, and we acknowledge its current treaty holders, who are the Mississaugas of the Credit First Nation. We also acknowledge that this is the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. And this territory is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share and care for the Great Lakes region. And with that acknowledgement, I'd like to just give a very brief introduction to our speaker, Dr. Firdosi Mehta. He's had an extraordinary career thus far. He's still extremely active internationally and here at York and more broadly in the GTA. Truly, at least in my view, an incredible exemplar of a wonderfully fruitful career over many, many years, and from a very now wise and old tree that continues to bear fruit. Firdosi finished his medical education in India before serving in the Indian Naval Defense Forces. He has previously held positions working with national governments in, for example, Oman, and also held major leadership positions in international health organizations such as the World Health Organization. And at the WHO, for example, and this is just one example among many of the things that he did, he contributed to the tuberculosis control programs in Somalia and Indonesia. And currently, Dr. Mehta is an adjunct professor here at York and a faculty fellow here at the Dahdaleh Institute. In his spare time, Dr. Mehta is a senior mentor and participates in multiple governance and advisory committees in some way related to public health in the GTA or the Greater Toronto Area and more broadly internationally. And these include, for example, the Committee to Reduce Human Trafficking at the Peel Institute of Violence Prevention, a role on the Center for Addiction and Mental Health Research Center here in Toronto, and also the Mental Health Equity Initiative in the Asia Pacific. And of course, he's still very active in Stop TB Canada. So today, Dr. Mehta will discuss his experience working with the WHO, focusing on disease eradication efforts and specifically on communicable disease control. He's also going to share some key lessons that he's gleaned for crafting effective health interventions that are centered around compassion, kindness, and empathy. And finally, Dr. Mehta will give some advice on practical networking and reputation building for young people largely, and some old, who are aspiring to work in the field of public health. So before just turning it over to Dr. Mehta, I'll just mention this is a 1-hour seminar, We'll end promptly at 2 o'clock. We'll start with a 20-minute presentation by Dr. Mehta, and then I'll have about a 30-minute discussion. I will start to wrap up sharply at 1:55, and we will end or conclude the seminar sharply at 2 o'clock. And I'd now like to ask Dr. Mehta to go ahead. Over to you.
Thanks, James. Thanks for the kind introduction, and thanks for having me over and inviting me in the seminar series. It's a pleasure to be over here. In fact, James, it's exactly 1 year. We met on April 4th over here in this meeting room, where you kindly discussed on inducting me as adjunct faculty fellow, and I'm glad I'm here. So thank you for the invitation, and nice to be over here. So, so in the next 20 minutes, what I will try to do is I will give you my journey over 6 countries, diverse countries, different realities, and what I learned along the way, what I contributed along the way, and a few lessons that will be my concluding as to what I learned and what anybody aspiring for a career in global health, international health, or any career can take away from. So my origins are from India. I come from humble beginnings. I come from a place called Ooty. It's in South India. It is in the Madras state. That's where I did my schooling, and then I did my medicine in Pune, which is about 100 kilometers away from Bombay. So my schooling was in Lawrence School, Lovedale. That was a school in Ooty, and the motto of my school was never give in, and that motto stood me in good stead of never giving in, and that I will tell you and prove to you as to how that stood me in good stead. Then I joined the Armed Forces Medical College in Pune. It is a very reputed medical college in India. It is the feeder of doctors into the armed forces. I did my undergraduate medicine over there. I did my postgraduate training in public health, and I did my board certification, and then I joined the armed forces for 11 years. However, right from the time that I was a student, medical student in Pune, I did not have that much of affinity for the clinical subjects like medicine, surgery, gynecology. My affinity was to public health. WHO was referenced extensively in our public health books, and my dream right from the time that I was a college student was to join the World Health Organization one day. My dream didn't come true overnight. It took a long time. It took over 20 years, but I did not give up on my dream, and that is where I said, never give in and have a dream. So I was in the armed forces, the Indian Navy, for 11 years. It was a good foundation for life. It teaches you respect for authority, systematic thinking, and it was a good life. But I felt that was not the be-all and end-all of my career or my career path. So I took a premature retirement, and then I applied for several positions out of India, and I got a position in the Sultanate of Oman as a public health specialist in 1989. So I moved from India to Oman with my 1.5-year-old daughter and my wife, and I worked in Oman for 10 years. So I worked in Oman. This is the Ministry of Health in Oman. This is the entrance of the Ministry of Health, and I worked for 10 years in Oman. Oman was a small Gulf country, oil resource rich, but very much committed to public health. I was one of the first expatriate epidemiologists or public health specialists who joined Oman, and I did a lot of work over there, and that's where my public health skills were honed. It was for 10 years working in the Ministry of Health, and I did a lot of work on the EPI, Expanded Program on Immunization. I contributed a lot to the standard operating procedures on EPI, and I'm very happy that to note, James, that the EPI is now 50 years old, 50 years old. And here this was in 1990. And this is where my public health skills were honed. I did a lot of work on polio eradication. We had a lot of collaboration with the CDC Atlanta. Roland Sutter was a very fine scientist from the CDC Atlanta, and Susan Robertson was from WHO headquarters. We did a lot of research studies on vaccine trials using IPV, OPV, etc. And I'm happy to say that the Global Polio Eradication Initiative is 35 years old now. It started in 1988, and I joined in 1989, and this was one of the landmark publications in the New England Journal of Medicine that was there. We did a lot of work. I was the polio coordinator in Oman, so whenever acute flaccid paralysis case was admitted in a hospital, I used to get notified. I used to go and see the case, take the history, ensure that the stool samples were taken, and follow up the cases at 60 days for residual paralysis, etc. So that was a very good experience. And not only on polio, did a lot of work on Congo-Crimean hemorrhagic fever and various other ones. I collaborated with a very fine infectious disease specialist in the Sultan Qaboos University called Dr. Scrimgeour, and I did a lot of work over there. I was the right-hand man of Dr. Ali Jafar Muhammad Suleiman. He was the Director General of WHO, in the Ministry of Health. He had several positions in WHO. He was the chairman of the executive board, and he was also, he did a lot of work on polio eradication. This was the Minister of Health, Dr. Ali Musa, His Excellency, and it was His Highness Syed Thuwaini on one of the days when the various health programs were displayed to them. So that was 10 years of solid experience, I would say. So that stood me in good stead, but I did not give up my dream to join WHO. And then with the contacts and my reputation that was built up in Oman, people knew me in WHO, people knew me in UNICEF, people knew me in CDC. But I got an opening for a 3-month appointment, just a 3-month appointment, to start as the country advisor on tuberculosis in Somalia. I took that and moved to Somalia in 1998. As you know, Somalia is a complex emergency country, volatile security. When I joined Somalia, there were only 9 TB centers. When I left after 4 years in 2002, there were 27 TB centers, one established in each district. In Somalia, there was basically this was the small 10-seater aeroplanes that we used to land on dirt strips. James, you'll be familiar with this, but not many other people are familiar with these situations. So we used to work in the different parts of Somalia. I worked with an outstanding lady called Miss Dr. Annalena Tonelli. She was from Italy. She was like a like the Mother Teresa over there. She did a lot of work on tuberculosis. Unfortunately, after I left Somalia in 2003, she was gunned down at the hand of a gunman over there. It was very, very sad and tragic over there. So this was the Boroma TB Center where Annalena was treating almost 1,000 TB cases. And in Somalia, the Damin system was used, that is the guarantor system, to hold a patient on treatment. And this was it's a nomadic, this is the TB Maniata, where they set up small huts around the TB center, and you hold them for 6 months till they complete their treatment. After that, I got the opportunity to move to Indonesia as the country advisor on tuberculosis over there. As you very well know, Indonesia just now is the second highest burden country in the world on tuberculosis. I went in 2002, and I worked with the Ministry of Health partners, etc., in a country where the largest archipelago in the world, decentralized health system. So rolling out the TB in such a huge, it spans from London to Tehran, the span of Indonesia. The Global Fund, I was very active over there, and that was also very good. There was a lot of human resource development. There was a grant from the Netherlands, channeled through WHO. So that was the initial 2002 to 2005 to roll out the human resource development across such a large country like Indonesia. Then we did a prevalence survey over there, going house to house. This was going down to the home level, and I always tell my students, my mentees, my staff, that all the answers are there at home level. And whenever you get an opportunity, go down to the household level, because that is where you will learn the most in public health or whatever else that you are doing. This was Dr. Davide Manicero. He was a JPO with me, a junior professional officer, working with me in WHO for 2 to 3 years. I'm very happy that I was a mentor to him. He is the Director of Medical Services in Quagen in UK, doing very well. We did a large number of ARI, that is annual risk of tuberculosis infection, in different parts of Indonesia, which also collaborated with this. So this was Dr. Vineet Chadda from the National Tuberculosis Institute in Bangalore, which is a very good reputed. We had him as a technical backstopping, and this was our team going down to the field level. As you know, the tsunami hit the world on Boxing Day in 2004. I was in Indonesia, and the province of Aceh, was one of the hardest hit, and overnight 150,000 people died. So that was one of the biggest natural disasters over there. After the initial stage, I went in with my TB team over there of instituting or restarting the TB program after the tsunami had hit. This is Dr. Yulizar. Dr. Yulizar was the head of the CDC. She lost her husband, she lost her house, she lost everything, but she was still at the table. So these are the heroes and the heroines which I have the highest regard for while working over there. The Global Fund was a big actor in Indonesia. I represented the bilaterals and multilaterals as the vice chair of the CCM, the country coordinating mechanism. That gave me a very good insight into the workings of WHO, and I worked tirelessly for getting the grants approved and then basically making the grants work, because there is a lot of fiduciary oversight. It isn't an automatic teller machine. Indonesia learned it the hard way. Their grants were suspended for a year because there was not enough fiduciary oversight, and that was also a very good experience in there. After that, I got the opportunity of moving to Sri Lanka as the country representative and the chief of mission. It was always my desire and my dream to become a WR. In WHO, you call the WHO representatives, they are known as WRs, WHO representatives. So that is, you represent the Director General and the Regional Director. So that was one of my best appointments that I had for the 16 years that I was in WHO. When you go, I went into Somalia on 1st of April 2009. The civil war of 30 years ended in mid-May. When you go in as a representative, you present your credentials to the Minister of Foreign Affairs. So it is an important position, but I always tell my students, mentees and all, it is not your position that counts in life, it is your disposition. I repeat that, it is not your position which counts in life, it is your disposition. And that is where I will come to empathy, kindness, etc. So the first 2 years in Sri Lanka, there were 300,000 IDPs, internally displaced people in the north, who had to be sheltered, fed, water, sanitation, and healthcare. So tirelessly we worked. WHO was one of the main health partners over there. We had several other partners, and with the Ministry of Health, no large-scale outbreak of communicable disease occurred, and there was no increased morbidity or mortality. Dengue was a major issue in Sri Lanka. So this was when we were distributing and providing support to the Ministry of Health by giving them fogging machines, etc. Now, through my career in Somalia, in Oman, Somalia, Indonesia, my thinking cap was communicable disease. But when I came to Sri Lanka, I realized that they did so much with so little. And that so much with so little was due to the establishment of public health programs, dividing the whole country in medical officer of health units, where preventive, promotive, rehabilitative action was done. But the main problem was NCDs over there, non-communicable disease. During my time, we took a lot of effort, we took a lot of initiative to address non-communicable disease in a low-income country. And we produced this document as the lessons learned. And every year in Professor Emily's class, in fact, just yesterday in Professor Emily's class on chronic disease, I present a case study of Sri Lanka addressing non-communicable disease. I did a lot of work on gender-based violence. This was another issue which needed championing on that. There was an NGO called Women in Need we worked quite closely with them, and did a lot of work on mental health also. And another problem in different parts of Sri Lanka was chronic kidney disease of uncertain etiology. We did a lot of research over there, and with the help of Dr. Shanti Mendes from headquarters in Geneva, we did a lot of research over there, and we found that arsenic and cadmium had gone due to widespread pesticide use, had gone into the food chain, and that was what was causing CKD of uncertain etiology. So this was also a landmark publication that we did. This was my team in Sri Lanka. This was my office. They have moved from there. I had about 40 people over there, but now they have moved to a different location. Now, as you know, WHO is a decentralized organization. So the Sri Lanka, Indonesia comes under the Southeast Asia region. We used to go to the regional office twice a year as the representatives. This was Dr. Samli Pliang Bangchang. He was my regional director for 10 years. This was Dr. Poonam Khetrapal Singh, who took over from him for the next 10 years. And now it is Ms. Saima Wazid from Bangladesh, who has been elected as the next regional director. When I left Sri Lanka in 2014, the Sri Lanka Medical Association is one of the oldest medical associations in the Asia-Pacific region. I was humbled and honored. They had never given an honorary fellow to any non-Sri Lankan. I was humbled and honored when I left due to my contributions that I was inducted as an honorary fellow into the Sri Lanka Medical Association there. So then after 2014, I came to Canada, and I've been here for about 10 years. I met Harvey and Mary in 2015 due to the kind introduction of Dr. Arun Chokalingam. I've been an adjunct professor here in York University since 2015. I contribute to several courses in Professor Emily, Professor Godfred Boating, Professor Iavo, etc. And what I bring to the table is the realities on the ground. And I do a lot of mentoring here at York University. In fact, in 2016, 2017, I helped the Global Health Students Association start up a mentoring program. Again, I was humbled and honored in 2022 when the School of Global Health instituted a prize in my name. It was a service prize for a student who has demonstrated exceptional service capabilities. And when I came on campus in 2022 for Godfred Boating's class, I met the first recipient, Miss Urmi Shet, and it was a humbling, and it was a pleasure and an honor to see her. She is now a medical student. She is pursuing medicine, and in 23, Miss Ayumid has received that prize, and I wish them well. I do a lot of mentoring on another platform called Multipod Mentoring. Dr. Fernando Zachariah is the executive director, so I've been active for the past 5 to 6 years on this. And I always tell my students and my mentees that a mentor is a little older, a little wiser, from whose hindsight you can gain foresight. So that is what I try to do. So now coming down to what are the opportunities for young professionals to join WHO. There is the JPO program, usually supported by country programs. Like I told you, Dr. Davido Menacero was from Italy. So Canada also supports this JPO program. Internship programs are available in different parts of WHO, both at headquarters, regional office, and country office. I'm very happy to say that one of the mentors, one of the mentees, Ms. Thadsha, was one of my mentees, and she did an internship program in WHO Sri Lanka office. So that was, she found that to be very good. UN Volunteers is another avenue, and the Young Professional Program is mainly for low-income countries. So these are various opportunities that are there. I end now with a few words of inspiration and what I have learned. I don't know whether many of you know that the first Director General of WHO was Dr. Brock Chisholm. He was there from 1948 to 1953. And in 1953, Dr. Brock Chisholm gave a talk on international service. And this was in the document when I first joined WHO. And this was in the document that perhaps the first requirement for people who join international service is empathy, and the person should have patience and persistence and self-reliance. And lastly, he says, why should the question of reward, why should international civil servants take on this difficult job? And the answer is the great privilege in which we share is that of working for the people of the world, all of them in a brotherhood of service. So I end with my takeaway messages. One, have a dream, but a dream will not become reality through magic. It takes sweat, determination, and hard work. Number two, be passionate in what you do. Have passion. I always say passion is the baking powder of life. You have it, you rise, otherwise you remain flat. Number three, Audrey Hepburn said, nothing is impossible. You just put an apostrophe after I, and it says, I am possible. This was true because I was told that being an Indian and from India, it would be very difficult for me to join WHO. I did not give up my dream, and that dream became possible by putting an apostrophe as to I am possible. And then the unbeatable trio is patience, persistence, and perspiration. Nothing comes easily, and patience and persistence is what counts in life. This is my farm in Lanark County. I have a farm over there. I spend most of my time over there. I have my city home in Mississauga. I have about 40 sheep. I have a llama. I have a pony. I enjoy it. Anytime you are past, it is closer to Ottawa. It is in Lanark County, and Lanark County is the maple syrup capital of Ontario. It will be a pleasure seeing you there if you ever pass by. And yes, and just to draw your attention that the WHO's triple billion goals, this is a short YouTube for 3 minutes, which will give you, I'm not showing it now, but it is a good source to give you an update on the triple million project. So that's over to you, James.
Well, thank you. That was fantastic. That was an incredible tour de force of your career. I know that's literally just touching the map, or showing us on the map the kind of things that you've been involved in. But really, really wonderful. I have a number of thoughts and comments, but I think I'll just first invite others to comment. Imran, did you want to ask a question? I thought you were telling me you wanted to. You were sort of.
Sure.
Yeah.
Thank you so much for the presentation. It was wonderful to hear that whole story arc put together. It's very inspiring and highly prolific. Thank you so much for sharing it. I want to probe a bit about where you saw the technical need for public health interventions interacting with or conflicting with politics. Where did that emerge in your work, and how did you resolve those tensions when they did arise?
So your question was where the technical
Yes.
need?
Where it's clear what you need to do technically,
Yes.
but there are political barriers to doing it. And how did you overcome them? When did you encounter that kind of situation, and how did you overcome it?
Yes, yes. So this constantly happens. This constantly happens in public health, and especially if you're working for the WHO and working for ministries of health, etc. Now, just to give you an example of when the H1N1 outbreak happened, I was in Sri Lanka over there, and the WHO was rolling out the vaccines to the countries. I'm not talking about COVID. I'm talking about H1N1 earlier. That was so. At that time, basically, Sri Lanka had just had some acute problems with the immunization program, where a few children had developed anaphylaxis, etc., due to the school health program that was being rolled out. So at that time, we had positioned the vaccine. The vaccine had arrived in Sri Lanka, but it was a very politically unstable time at that time to roll out the vaccines at that time to cause any adverse events which are related to the H1N1. So the Minister of Health, when we had discussions with him, he said, hold on for a little while. Basically let this furor go down. So we held on for a week or two for that, and then it was rolled out. So constantly you are faced with these issues, and I call it politicology, and I've learned politicology going through 30 years in different systems, where you have to make a balance between the technical issues, political issues, the need on the ground, and it's a constant balance that you have to play.
Great, thank you very much. It's very illuminating.
That's great. I would invite others online to ask any questions or pose any comments, and particularly, I see Harvey. I know you, Harvey, are a longtime friend and colleague of Firdosi, and I wonder if you, as another great old lion or old oak that's still bearing fruit, if you have any thoughts or comments that you'd like to make.
Well, it's so beautiful how you told your story graphically and with humor and your profound insights. You know, you just have some great turns of phrases. And so I think that's, incredibly motivating. I know that we're so fortunate to have you here at York and engaged with our global health students in the classroom and serving as a mentor, because I know they look up to you and your lived experience. It's really quite remarkable. And you started with a dream, and our students all have dreams, but I think we really need to encourage them to really articulate that dream. And I often try to dream a bigger dream. Don't sell yourself short. Dream a bigger dream, and then you got to go through a lot of small steps to implement it. But to keep that dream, and I can just see that permeating your story. your dream was to be WHO and to have impact, and so now you're looking back. My question, I guess more at a personal level, you lived in some difficult situations. What did you do, and I guess your advice for others to just take care of your own personal health? I mean, physical, sort of the mental health, and to keep yourself kind of grounded, because I know you're in some, politically there's some difficult times. So what did you do? What's your advice? Because I mean, our vision of our work here at York is we can't heal the world unless we're also healing ourselves. So, and you did so much, healing the world. I'm just interested in, at a personal level, what the sort of things you do and your advice to keep yourself resilient.
Yeah. Thanks, Harvey. Thank you. And it's a pleasure to see you. And I would say it was Arun's introduction to you and Mary in 2015, which brought me to York, for which I'm very grateful for. And it's always a pleasure to see you and Mary and others this thing. Yes, the most volatile security situations were in Somalia. And now, as you know, Somalia is a non-family station where my family was based in Nairobi, Kenya. We had liaison offices over there. So the family was based in Kenya, and I used to fly in these 10-seater aeroplanes, etc. Security was a major issue, but we always operated under the UN security umbrella, where we had to, first of all, have training on UN security and security issues. And we always were advised where it was safe and where it was unsafe. Now, in terms of resilience of some people are born resilient, some people learn to be resilient, some people have more resilience, some people has less resilience. So we always had the facility of basically seeking any mental health support that we needed in these different countries. But somehow I managed with my resilience. But the question, Harvey, that you bring up, it was hard on the family. It was hard on the family to move from 6 different countries, different cultures, different schools. I have 2 daughters. Both of them are well settled in Canada. I have a granddaughter. But it was difficult because they never had any roots. And I'm happy to say that after both my daughters pursued university over here, so that was a stepping stone to Canada and making Canada their home. And that is very important, to have roots in one place. They have seen so many different cultures and customs and communities, which has given them a very broad outlook to life and given them much more. But it was hard on the family, and that needs to be taken into consideration.
That's great. So, Dr. Mehta, I have many thoughts, but I'd just like to ask you, I see permeated throughout your various postings and your various initiatives, very much I don't know how to put it, but a very clear respect for science,
Yeah.
and a very clear not only orientation towards effective program delivery, whether that's around polio eradication or EPI or TB or dengue, whatever. Very much focused on effectiveness, but also very much focused on building science and a research capacity into what you're doing.
Yeah.
Do you want to just, and I noticed that, I mean, very clearly, you've made also, as well as making very, very significant contributions in terms of operational clinical public health. You've made huge contributions in terms of science and in terms of knowledge. Do you want to talk a little bit about that relationship?
Yes. So that opportunity came in the different countries. I would say that it started in Oman, when I was there in Oman. And as I told you, I was the EPI coordinator, the polio eradication coordinator, etc. And as I mentioned, the New England Journal of Medicine publication that came, Oman developed collaboration with different actors, the CDC, WHO, various things. So Oman accepted the input and the collaboration of different actors to use Oman as a site study or a country study to roll out these research programs. Now, doing research, especially for immunization program and vaccines, is very rigorous. It isn't sort of hogwash or anything. It is very rigorous. So that was a good stepping stone. Second was documenting the communicable disease landscape over there. And third was documenting Oman's basically lessons learned of dealing with outbreak situations in these things. So was it continued in Indonesia and in Sri Lanka afterwards.
So here's a slightly more, I guess, difficult question in the sense that there may not be a self-evident answer. But I think of polio. And in my own experience, I remember in the late 80s working in Central Africa and going into small towns and villages and seeing hundreds of people with polio, adults who have lived a lifetime of that particular disease, and children with new onset polio. And then I was also involved in the initial stages of the EPI program, and then seeing the impact of that, right? And the profound reduction in the number of cases of polio. And then again there, the issue of science, how important it is, one of your papers was actually on what is the efficacy and the added immunogenicity with a fourth dose of OPV. Right, and it was huge. It was very, very important for the clinical outcomes associated. So now the question is, I think it's a question that people, only older people with prior experience can even imagine. And the question really is, how do you prove a negative? In the sense that how do we explain to people that polio is real when they don't see it anymore, right? They don't see it as part of their lived experience. Even in North America, you're very aware, we had polio epidemics here in the 50s and all the way into the early 50s.
The iron lungs were here.
And so on and so on. But that has left public consciousness. We now, to fast forward, we now have a very strong anti-vax movement.
Yes.
And I would say, that it's quite important to be careful about that. Not to you, but most people who are anti-vaxxers, they're not evil people, right? They're people who are genuinely concerned about their own children. And about, am I going to harm my child or am I going to benefit my child? And so the challenge really is, in terms of vaccination, just as one example, we've lost the consciousness of that negative experience. And one of the great challenges in public health always is, how do you prove the negative? How do you prove the thing that you did prevented a worse thing from happening? So do you have any thoughts on that? Or is that just something as clinical public health practitioners we sort of have to live with?
Well, we have to live with that, but the question is, it's not over yet. It's not over yet. Afghanistan and Pakistan, basically, poliovirus 1 is still, indigenous transmission is still taking place. And until that last bastion is won, and it is very difficult now, it is more than moving from science to EPI programs. It is security, culture, customs, habits, etc., which is there, And I think the world is at a point where they are not going to give up to meet the target of polio eradication, but the last mile is going to be difficult. Now, your question about how do you bring awareness to the people as to that it be not a forgotten disease. That is basically advocacy, etc., etc. But it is part of life as a new pandemics and new things that will occur that catches the attention of people. But these are the things that we as public health practitioners need to discuss and need to persist. And I think basically we need to finish the last mile over there. And I will be a proud person when the world basically is declared as polio-free.
And it's not far off.
It's not far
and
off.
there certainly are challenges around new genotypes of polio emerging from live vaccines.
Yes.
That are being studied very carefully as potential sources of new infective capacity or new outbreaks. But I think my sense is that we're very close. And so let me just try to sort of wrap up some thoughts. Just listening to your story and to the arc of your story, you're so very consistent with what this institute is all about, which is all about critical problem solving. And that's a very particular phrase. It's about understanding and illuminating a particular issue from a critical perspective, and not necessarily with a perspective of destroying or damaging a particular understanding, but with a view to illuminating that understanding so that problem-solving initiatives can be engaged. And you've certainly done that in the most incredible ways over your career. The other thing that really strikes me is that, reputation. You mentioned this early in your talk, how important reputation is. And I just would really emphasize that, especially to younger people and to younger students, that your reputation is your calling card, and you can have the best website, you can have the best LinkedIn page, you can have the best social media presence with nice glossy sort of images and everything else. But the bottom line is we are human beings who are social beings. And we give great value to trusted opinion and to trusted perspective. And reputation is held in the hands of others. It's not in your hands. It's held in the hands of others. And it is their evaluation of who you are and of how you function and how you behave. And when a trusted person tells another person who's inquiring about you what their view is of you, that has far greater impact than anything else, than social media, LinkedIn, whatever. So your reputation truly is your calling card. And the comment that Dr. Mehta made, which I thought was fantastic. It's not your position, it's your disposition that matters most in life. It is your disposition that will create perception, or that creates the perception of you. and how you behave, how you cope with different things, how you engage different issues, whether or not you respect other people, whether or not you have respect for yourself, whether or not you see the fundamental dignity of others. This is really, really key, and I think you've brilliantly highlighted that, and I really hope that particularly our students and our younger people are listening very carefully to that. And then the other that you really highlighted, or that came across to me, was when you talked about each of the various situations and circumstances and programs that you were involved in, you actually never talked about yourself, except that there was once where you talked about one little thing. But in every single case, you pointed out one person in that photograph, and you talked about them, and you talked about what they did, and how much they contributed to the program, and how much their success, the success of the program, was dependent on them. Now, to me, that says a lot about you. And it also says a lot about what is clinical public health. By definition, it's a team activity. There are no superstars without stars, right? And I've said that to a few people over the years. If you want to be good at something, you must make everyone around you a star, right? Everyone who is contributing, they have to be acknowledged for what they're doing. They have to be supported, they have to be enabled, they have to be encouraged, they have to be given the right resources, and that's your job. And I think, Dr. Mehta, you've highlighted that multiple times in your presentation and in multiple different settings. And I think the main sort of thing is that you really have given us a perspective from a person who's looking back, who's a little older, a little wiser, and who is able to offer some suggestions for those who are looking forward. And I think you've done a brilliant. You've given us a brilliant presentation, and more importantly, you've also given us an example of what a good, meaningful career in clinical public health looks like. So thank you very much for that.
Thank you, sir.
Yeah.
Thank you very much. Thank you.
So with that, I'm just going to close and again say thank you, Dr. Mehta, and thank you, Hannah, for organizing and keeping things technically kind of fluid and functional. So thank you for that. And also to all of the participants who've joined us today. And our next event will be the 6th Annual Global Health Intern Symposium, and that will be taking place on Wednesday, April 17. Wednesday, April 17, and you can find out more about that on the website. And with that, I'll call the seminar to a close. So thank you, everyone, and see you on the 17th.